But anyway, at that point, we can get started. And I'd like to welcome Professor Mohammed from the Strategy Unit, who's going to lead the session with our two eminent guests. Thank you.
Thank you. I'm a principal consultant at the Strategy Unit. I have a background in academia, but it's my great pleasure really to welcome you all and to introduce our two special guests for today's session. I'll start with Dr. Ben Goldacre. Ben is a tour de force really in so many different areas that it's really not possible to do justice to Ben's CV in a short introduction, but just some highlights for those of you that may not be aware. So Ben is a doctor, an academic, a writer and a broadcaster. His academic and policy work is in informatics, epidemiology and evidence-based medicine, where he works on various problems, including variation in care. He also has a special interest in retracted papers, by the way, if people are interested in this. He runs a data lab, which is a multidisciplinary team of academics, clinicians, and software developers working together really to pool large data sets. The OpenSAFELY is an initiative which involves the use of primary care research data and a platform that provides access to 24 million electronic health records from primary care. And it was used during the COVID emergency. Open Prescribing is another initiative that Ben is closely involved with, and he's a principal investigator on the Trials Tracker program to look at the reporting of clinical trials. In his policy work, he chairs the Health Technology Advisory Board for the Secretary of State for Health and Social Care, and he sits in the Ministry of Justice Data Evidence and Science Board, and he's authored numerous papers and reports. Perhaps his most well-known book, popular book on science, is the Bad Science book, which some of you no doubt will have read, and it's notorious for it's characterized by allowing people to get a basic understanding of the scientific method, so that we can all become better at identifying bullshit. So Ben, if I can hand over to you, and then after your presentation, there'll probably be some Q&A, and then Andy, I'll do your introduction after Ben's talk, if that's all right. Just while, if people, I think we're going to just allow the speakers to go through their session, but you can always post questions into the chat box, and you can also raise a hand if you want to bring my attention at the Q&A. So over to you, Ben, please. Thank you.
Hey, thanks a lot. Thanks for having me. Can you hear me okay? Is that adequate?
Yes, Ben, we can hear you loud and clear. Thank you.
Good. And also, can I make an unusual request, which is it's quite a strange, lonely experience trying to pitch an idea at a bunch of people when you can't see them. Could you switch your videos on? Would that be all right? Have you deliberately switched them off because you think it'll crap? I promise, even though the session is being recorded, nobody will judge your spare bedroom any more harshly than they'll judge my spare bedroom. Hey, look at you all. Ah, all right. Okay. And there's a reason why I want you here and why I want you visible, which is I'm on a kind of, it feels like a kind of geek road tour of trying to pitch people on a bunch of ideas around how to modernize practical analytics in the NHS. And there is a massive kind of challenge doing that over the internet, which is that some of these ideas could easily put people a little bit on edge, not for any reason other than misunderstanding. So to talk about problems and how to fix them, you have to talk about some of the shortcomings in the ways that things work at the moment. And I'm fully on your side, and I know there's lots of really great stuff happening, but if I can't see the whites of your eyes, I don't know if you're going, oh, you're talking about Jupyter Notebooks. Don't you know that we all use Jupyter Notebooks in Leicester, you tool? So that's why, although I can't properly see you, can you, if you approve of what I'm saying, can you wiggle your hands in the top half of the screen? And if you think that I'm just a monstrous, awful human being, wiggle your hands in the bottom of the screen. And then I have like live feedback on how to pitch a difficult pitch. Is that okay? Is that needy? I mean, it is okay, but it's sort of needy, is what I'm getting from the finger location. You can calibrate your finger locations looking at your own video. Right! Okay, so here we go. I'm going to run through three things very quickly if we get time. Number one is I want to whiz through a paper that we published in the Journal of the Royal Society on Medicine, which is about how to modernize practical coalface analytics in the NHS. Number two, I'd like to talk about how OpenSAFELY works, which is an open source, general purpose, script-based trusted research environment that we've built during the COVID-19 emergency that's running across an unprecedented scale of patient data. And then very finally, if we get a chance, I'd like you to run you through very quickly just one Jupyter notebook, because I know a lot of you have seen them, but they are, to my mind, the best kind of real practical, hard, black and white distillation of the power in new ways of working. So I'll send the links around later, and I'm not going to use slides because slides are awful, and also my quite elderly MacBook will crash if I try to use slides. So data, right? On the one hand, there's this sort of day job drudgery that we all fight. And on the other hand, you get people saying, oh, data is the raw material of the 21st century. And you see better use of data as a central feature of the long-term plan. And sometimes some of the things that you hear said about it don't quite chime with the day-to-day reality. Now, to be clear about where I'm coming from, my work is quite unusual in the world of kind of university academics working with data, because, as Mohammed says, we are first of all a truly mixed team of full stack commercial grade software developers working alongside traditional academic researchers and clinicians. And we don't just take large health data sets and turn them into pure academic research papers to be buried as PDFs in journals read by nobody. We take large data sets and we turn them into data-driven tools that turn raw data sets into knowledge, into insights, into action. So our most well-known thing, apart from OpenSAFELY, is Open Prescribing, which lets you see what every GP practice in the country is prescribing, down to the level of individual practices, individual presentations, individual doses of individual drugs, with about 100 standard measures. And I use the word measure advisedly, not indicator. You're measuring something, it's not proof, it's all about interpretation. And that gets about 135,000 unique users a year, 15,000 unique users a month, and those are unique IP addresses with thousands and thousands of subscribers. And it's all driven by quite hardcore data science under the bonnet, but on the front end, it's designed to be straightforward and usable. And there's something that has been really striking to us in the course of our experience building those tools, which is it's very, very easy for me to get money to do one clinical trial or one academic research paper. But as soon as you want to start using exactly the same skills to produce live interaction, data-driven tools and services that are used by large numbers of people, suddenly there's no competitive funding available. But also, offensively and very misguidedly to my mind, doing that is regarded as being somehow of lower status or somehow easier than doing a research paper. And having done both, I can tell you for definite that practical coalface analytics and general purpose tools and frameworks are vastly, vastly more difficult than doing something entirely in the abstract, entirely in principle. And they also require much tighter teamwork and much better discipline than the one-off process of write some code, produce a report, throw the code and the data in the bin, and just pray that nobody cares and run on to the next project. There's something about maintenance of ongoing data-driven tools and services that is very, very substantially different. So in the course of running around and befriending lots of people who do practical coalface analytics and working closely alongside them, over the last 2 years, in our group, we started building a kind of a wish list of things we'd like to see change to make practical coalface analytics work better. And we've summarized this in a paper, and many of the authors of this paper are here because there are dozens and dozens of authors for this paper. And we published it in the Journal of the Royal Society of Medicine, and I'll send around the link afterwards. And now I'd like to kind of run through some of the things that we said. So we're focused principally on practical coalface analytics, and that means the stuff that people like you do all day, every day, but which is completely invisible to many in academia and also in healthcare. It means variation in care analyses to identify opportunities for improving quality and safety and cost effectiveness. It means modelling around waiting lists or modelling around the optimum geographical location and size for new services. It means evaluating whether new interventions or reorganisations have achieved their, not just their clinical objectives, but also their logistic objectives. It means monitoring volume of activity and cost to ensure that people are getting good value from clinical contracts. All of that stuff is essential to delivering good patient care, identifying problems early and spotting efficiency gains. They require all of the same skills, methods and tools as traditional academic epidemiology research, and yet the practical analytics workforce, to my mind, gets very little formal training and has been largely outside of your narrow communities of AFA and of meetings like this, has been largely sidelined. In the olden days, the Lancet used to publish audits in the Lancet, whereas now things get lost in one-off reports, and there's a culture of analytics typically being done behind closed doors, not because of any fault of individuals, but because of a culture of how things are done. And this way of working behind closed doors, it blocks error checking and reuse. What's worse is that clinicians and commissioners often lack the skills that they need and the support they need to learn how to ask good questions of data. And consequently, better use of data to support decision making is, it's often variable, and sometimes it's done quite poorly. So we pulled together a small group trying to find out, or trying to set out, the technical barriers, the cultural barriers and the regulatory barriers to better use of practical data analysis in the healthcare system, to identify potential solutions to those barriers, because we didn't just want to moan, and then to frame those barriers and solutions as action statements in a standard format, because there's nothing I like better than a data structure. So specific person or organisation should do this specific thing so that this specific outcome can be achieved, and we'll whiz through some of those towards the end. So overall, we set out, I think, a really interesting collaborative vision around the need for a 21st century NHS analyst workforce supported by clear career trajectories and training opportunities. A culture of script-based analytics rather than point and click. A culture of build it once and share it to everyone, built around modern open analytic methods. Capacity building for non-analyst staff to participate in better conversations around data. And lastly, frameworks to try and help ensure that we get good value from externally commissioned analytics, where, as we know, as before, standards are at best variable, ranging from people borrowing your watch to tell the time through to real amazing gold standard stuff that genuinely nobody currently in the public sector could achieve. So, first up, shouting very loudly is less effective if you're not in the room, it's just distortion. Oh wow, Lauren Bland, you're wearing a mask. Oh, you're at work, I can see from behind. Oh, that's very good. Right, okay, so first up, 21st century NHS analyst workforce. So at the moment, nobody knows how many analysts there are in the NHS. Martin Bland, in his paper for the Health Foundation, estimates about 10,000. Most of these people are in very junior roles. They're focused on data management, and those jobs are advertised and classified under the Agenda for Change pay bands as administrative / clerical rather than scientific / clinical. And I think that in itself is almost a kind of poetic illustration of the challenges that we face. The people who press the buttons in the path lab to push the full blood count through the machine are regarded as scientific / clinical, whereas the people who do often very hardcore advanced data science are classified as administrative / clerical. I want to see you waving your hands up here, but maybe it's just too boring. God, Judy Wiltshire cares. Look, I'm not needy, honestly, just respond as you wish. Okay, so analysts overall, they get very little guidance on the skills they need to progress, and there's very little strategic thought around providing inspiring leaders to look up to. It happens locally, it happens by accident, it happens because of individual single inspiring leaders, but there's no structure. And that's compounded by the fact that despite being very technical and, as I said, closely mirroring epidemiology research, operational research has evolved over time largely through informal sharing of methods among practitioners rather than by developing a formal literature or a commons of knowledge. If you want to go and work in this field, it'll be extremely difficult for you to find a textbook, a course, a blog, a set of a manual, a Haynes manual, Typically, you'll be told, go and sit next to Janine Della or Alison Wint or Jill Kent, and they'll help you out. Just learn by example, gradually build it up. Now, for the NHS and patients to benefit from a high quality practical analytics workforce, we need a range of skills and skill levels, delivering innovative, efficient data analytics on questions that matter to clinicians and commissioners, policymakers and patients. And to create that, we need clear career trajectories, systems and structures for effective development and training opportunities. So first up, you need opportunities for career progression that are formal rather than accidental. You need a way to recognise and appropriately reward analysts' technical skills, which can have a really high market value outside of medicine, without requiring them to become a generalist manager in order to rise in seniority. There is a terrible problem in the NHS and in academia. The way that seniority is recognised is by how many people do you manage rather than your productivity or your market value. Now, in other bits of government, things are a little better. So there's the government analyst professions, there's the government economic service, the government statistical service, the government operational research service, government social research service. They have things like a head of profession, clear career paths, progression opportunities supported by genuine continuing professional development, which is run both locally and to national standards. They hold their staff to high standards by setting out clear best practice guidelines. They give accreditation. They require analysts to adhere to a clear code of conduct. And this is all the practicality and the theatre of creating a profession with status. This parallel means of management and of CPD also brings not just a commons of knowledge, but also a community of practice. And a community of practice is a really important concept. It's most powerful when you have a profession that is highly technical, where you need CPD or mutual internal networking and support, but where there's only a handful of you in each organisation. And that's the shape of the analytics profession. There are 5 analysts in a CCG. There are a few analysts in a trust. They are overwhelmed by the scale of doctors, nurses, physios, OTs and managers. But there are thousands of analysts across the country, and building those parallel stripes through the professions and networking people is extremely powerful. And doing it informally, which is my impression of how things have happened today. I mean, AFA, I love AFA, and I love Paul Stroner, but it's 37 quid a year to be a member because Paul is shy of asking people for too much money. Meanwhile, I pay 450 quid a year for my Royal College membership fees, 430 quid a year for the BMA, 400 quid a year to the GMC, which is obligatory just to be allowed to continue being a doctor. I lose £1,200–1,300 out of my bank account every single year for these professional bodies which go off and represent me, go off and do stuff. And there is a machinery there to build CPD, recognition, reward, political presence. And I think, honestly, you don't get anywhere without that kind of basic machinery, however painful it is. So you need that, but you also need formal reclassification. I think analyst roles, as a matter of kind of basic principle, need to be classified as scientific/clinical rather than administrative/clerical. That simple act of reclassification and thoughtfulness will require the creation of things like a national competency framework and also a pay scale. You go and look on jobs.nhs.uk or whatever it's called, and I'm sure many of you do, and you'll find adverts asking for a sort of, you know, people who've got expertise in Python, SQL, YAML, all kinds of stuff where in a commercial environment you'd be asking for 60, 70 grand a year, and yet there's no job advertised as an analyst over 36. You know, it's foolishness. But you can also retain people by making a good offer to them. Looking further into the future, I think it's likely that things like a Royal College of Analysts or equivalent is necessary. And just thinking about how things are done elsewhere, I don't know if any of you have ever been to AMIA, the American Medical Informatics Association meetings, or similar in America, but those are, you know, they're held in baseball stadiums. They're not 100 people, they're thousands and thousands. So clear progression and pathways, that only works if you have training to underpin it. So I think there's a huge range of opportunities here. And when I say I mean we. For example, school leavers might benefit from NHS data analyst, data scientist apprenticeship schemes. Undergraduates and postgraduates would surely benefit from degrees in applied analytics for health and social care. And working professionals need accredited certificate programs offering specialist skills training, albeit that we know that going off and doing the Python course on Code Academy in the 7 days free trial is a really powerful and valuable way. Being a DIY personal developer, it makes a difference. Formal classification and formal certification is also really important. And lastly, we need those courses, we think, to be massively open and online. Because the number of people who want to do, well, the range of people who want to understand this stuff extends quite rightly beyond the kind of people who come to this meeting. If we want to have people in senior leadership roles, if we want to have data literate managers who can ask better questions of their analysts, then we need to make it easy and accessible for people to find out what it is that we do all day. So obviously none of that's going to be free. And we've discussed various options: arm's length bodies, local national NHS organisations, national funders, Health Education England, NHS Leadership Academy, academic groups. There is an unending palaver of people who can and should get involved in shipping this. The question is, and I'll be taking email addresses at the end, how do we assemble the Viking squad that's going to make this happen? So, next. Ways of working, and I think this is where it might get sticky, because some of you may say, we already do this, you buffoon, and some of you may say, we don't want to work like this, I don't know how to work like this, and I'd rather not, if that's okay with you. Public trust in NHS data, it relies on things like transparency and accountability. The same as any data analytics. Learning also requires on transparency. Complex analytic work in the NHS these days is currently commonly done in silos. It gets done by force of habit behind closed doors in national, local and regional organisations and in private sector organisations. And that's really problematic. It means that when people work using point and click tools behind closed doors, the results of those analyses are withheld from outsiders, and sometimes there may be legitimate operational reasons for not sharing the results of analytic projects. But also critically, it means that the methods used, both for data management, but also for data analysis, are not shared. And as a consequence of that, nobody outside the direct analytic team doing the work get to critically review the methods. Now, it can be hard having people outside your group looking at what you've done and poring over your work, but the benefits are phenomenal. People can spot errors and fix them. They can learn from the work that you've done and replicate it. They can take your code and your routines and they can rerun them on their local data and reuse it efficiently, creating a growing library of analytic approaches. And if we don't have that, then the system's deprived of a commons of knowledge that doesn't just help individual people who are currently in the system to work better, but it also deprives us of a commons of knowledge that would help to train new staff and inspire existing ones. It deprives us of a commons of knowledge of worked examples that provide the kind of formal and informal structures and guidance and learning by example that you get from collaborative improvement on analytic methods, from being able to see the work that's being done. And I think that's a really important opportunity. I'll go through a Jupyter notebook later on to show you in kind of more concrete terms what I mean for those who don't see them in their daily life. But I think just before you even get to Jupyter notebooks, it's really important to reflect that if you're interested in pediatric oncology or renal medicine or any medical specialty, you could fill spare bedrooms like this 10 times over with textbooks from those specialties. In the field of operational research and practical analytics in the NHS, I think you'd be lucky. Hands up who thinks they could name 4 textbooks that would teach you how to be an actual practical cold-faced data analyst in the NHS. Not epi books, not stats books. Who could name 2? Some of you are looking from side to side, which is quite disorienting because I know you're not pretending to be in separate rooms. Who could name 2? Who could name 1? Come on. I can only see about a fifth of you, but I think I could name one, but I don't think I can name more than one. So, as a starting point to start building that commons of knowledge, the best way to do that is to immediately leapfrog into the future. You could go beyond what most academics do, move away from point and click analytics and embrace the benefits of modern open analytic methods with reusable scripts and open source tools like Python and R and Jupyter notebooks. And that will benefit the existing analytic workforce. It'll attract more highly trained data scientists who are used to working in this way to come and embed themselves in the NHS. Now, this doesn't just require that individual people say, hey, I'm going to go and learn, I'm going to install Anaconda and learn how to do Jupyter notebooks. It requires that, first up, senior leaders have to make it clear that these are acceptable methods for people to use in the NHS. They've got to promote it and support it, reward it, they've got to permit it. Actually, one of the most powerful things that Ben Warner in number 10 did around the government data strategy was to essentially instruct or help make it so that government departments allowed their analysts to have Anaconda, Jupyter Notebooks and R installed on their laptops. And I know, because I've met dozens of NHS analysts who want to use R but are blocked, R and Python, but are blocked by their local IT team from being permitted to do so. So you have to permit it, you've got to encourage it, you've got to recognize it, you've got to reward it. And going beyond just isolated use, we need to see more active support of platforms like GitHub, not just for sharing code when it's finished and done at the end, not just as a notice board where you paste it, but using GitHub as a platform to develop code collaboratively as part of a team, to raise issues, to get things fixed, to have positive, open, collaborative development of code in the open. Also using tools like Stack Exchange, where it's meat and drink for people to go and post questions and answer them. Again, building that commons of knowledge around what to do when you're blocked, what fields in HES aren't trustworthy, what the real differences are between CTV3 and SNOMED CT, all of the different bear traps that we face on a day-by-day basis, to start building a commons of knowledge around that. And to do all of this well requires a collectively and modestly resourced effort to create that kind of public library. And ideally, a public library of tagged and edited and curated workbooks, how-to guides with patient data obviously stripped out, but code that can be readily reused. Now, data controllers, regulators, policymakers, and employers can make all of that easier. They can support it by making it mandatory with acceptable exceptions, but to make it mandatory as a general rule for NHS analysts to share code in this matter, make it the default to share. Don't ask people to seek permission separately in 200 CCGs and 200 trusts and 47 ICSs. Don't make 450 people have a conversation with their boss that goes, what, sorry, talk me through this again, what's Creative Commons and MIT open license, and I don't really understand open government license, and why are we giving this away for free when we should be charging people for it? If it's any good, isn't this intellectual property? We need a proper, thoughtful, national strategic discussion about around what it means to share code. It also, I think, needs that we need conversation and community, whether it's pushed by AFA or decision support units or the NHSR community or the imaginary Royal College of NHS Analysts, to push forward conversations and community around the wider adoption of these tools. Lastly, examples of great work deserve a wider airing, and they also need human interaction. So I think conferences are the thing that is also really strikingly not entirely absent. I've been to AFA, I've seen it with my own eyes, and I've watched the videos of the previous years, but the kind of community that you get from regular meeting built around a coral reef of practical sharing rather than discussion is not to be sniffed at. Next, the importance of pooling technical skills and domain knowledge. So I think this is really important. Good data analysis is contextual. I've lost count of the number of times when I've come across people who've thought, oh, we're going to do something completely amazing. We're going to get a data scientist and we're going to embed them in the NHS. And they employ somebody who has got a PhD in bioinformatics or something about protein folding. and then they throw them into an NHS trust and they're baffled when nothing particularly interesting comes out at the other end. The challenge and the beauty of what all of us do is that it requires us to know a little bit about a lot of stuff. It requires us to be fluent across a whole range of different things, including not just the practical aspects of data science and the esoteric aspects of statistics, but also what people will use that data for locally, what the raw data actually means, how it was collected and for what purpose it was collected, which helps us to understand which bits are likely to be reliable and which bits are likely to be tick box and just to get rid of the pop-up on the EHR system. And also local practical knowledge around what kinds of message and what kinds of style of communication are likely to work on what kinds of customer. And that's both by class of customer, but also by individuals. Some of you have got chief execs who know what they're doing. Some of you have got chief execs who don't care as long as the graph has a pleasing color palette. Some of you have got CFOs who have very different skills to your chief exec, and you know that you're speaking to different people in different ways. Context knowledge combined with general data science skills is a phenomenal superpower. And it's one that very rarely gets written down, but it's the only way to get your outputs used to inform practical decisions in a system. So that's why I think we also need to see a rethinking of how NHS analysts and decision makers work together. Now, over time, people keep sort of vacillating. You can watch the oscillation in most government departments. Sometimes they go, oh, there's a problem. The analysts don't have enough of a center of gravity. We're going to put all the analysts together so that they can all bounce ideas off each other and reinforce each other. And then we go, oh no, it's dreadful. The analysts aren't close enough to the policymakers and the decision people. So we're going to push them all out and embed them. I think what we need is something where we recognize the power, both of people being embedded in the people alongside colleagues who make meaningful decisions, but also being close enough to have a commons of knowledge and to have the kind of networks that they need. And lastly, that's the only way that we get to help staff become better customers and users of data. So managers and clinicians often feel out of their depth when they're commissioning and evaluating the analytic insights that are provided to them. And conversely, and I've been on various sides of this and I've watched it as well, analysts can sometimes feel quite frustrated by senior leaders making unreasonable demands or asking unrealistic questions or wanting to view numeric outputs as concrete indicators rather than practical measures that can be used to initiate a discussion. It can sometimes be challenging to communicate to people that some things can be done very quickly and very cheaply and very easily, whereas other things, which externally might seem to be almost identical, other tasks can be almost impossible, might need 6 months and a team of 5 to achieve. Now, this kind of disconnect between users and providers, this kind of disconnect between the user need and the analytics delivered is destructive. I think as a starting point, NHS organisations need to build an expectation that non-analyst staff, at least sometimes, will have sufficient data literacy to be able to conduct informed conversations about data. And also to ensure that that's not an unrealistic expectation, we need basic training in data analytics for generalists, for clinicians and managers. I think we need some of this to be mandatory, but we also need to recognise that there are a range of skills and interests in all individuals. If you look at any individual GP practice, you'll find that there's one GP who's really good at dealing with people with personality problems and substance misuse. There's one person who's really, really interested in Cochrane reviews and reading the latest meta-analyses and keeping everyone up to date. There's somebody else who's really interested in doing the accounting, and God bless them. It's fine for there to be a range of interests and views amongst the individuals in any organisation. But one way or another, we need to find a way for national NHS bodies to hold local NHS bodies accountable for making sure that there are local staff who have the skills necessary to participate in a good quality conversation about numbers and around data. And lastly, as part of that, we need more thoughtful use of outsourcing. So at the moment, it is common to find that work is outsourced or commissioned from one NHS organisation to another, like a commissioning support unit. Now that can be because of lack of in-house capability. It can be for quite legitimate reasons around not having enough of a particular kind of work for it to justify having the skills in-house. It can be because people lack technical capability to do jobs that they should be able to do. And it can also be, frankly, because NHS managers lack trust in their own analysts and want a second look or a second glance at the very least. Now that skills shortfall at commissioning level can sometimes result in weak products from the outsourced contractor, or at least a mismatch between aspiration and delivery. I'm speaking tremendously sensitively. Sometimes it can be really, really, truly laughable and terrible. And the sadness of this is that I meet people who work in large providers of outsourced analytics for the NHS, and they're not happy either. I've on at least 4 occasions, and none of them have ended up coming to work for us, but on genuinely 4 separate occasions, somebody's got in touch and said, look, I work for, insert name of large consultancy here. We are constantly getting contracts where we're asked to do a job which barely amounts to anything more than downloading some open data from PHE fingertips or some other open data source that is already in existence, throwing it into Tableau and then giving it back to them with a pleasing color palette and a slightly animated user interface. And furthermore, we produce something for one region where, having done that, we could give it to every region, but they don't want us to. They want it to be just their thing. And what's striking about those conversations, albeit that these are conversations with people in their 20s and 30s rather than people in senior roles in those organisations, what's striking about them is people don't want to work like that. People don't want to make money like that. They want to do something that's meaningful and useful. And I think it's not beyond the overall organisation to get to a place where we can have outsourced analytics that is done to genuinely push things forward, to genuinely meet needs, because there is, without question, a spectacular amount of very, very, very high-end data science consultancy that can be extremely valuable for the NHS. But what we need is for senior leaders in local and national organisations to have the skills necessary to recognise value, to task people to correctly, and to evaluate the sorts of product that they get back. So, is that enough rambling about that? Shall I talk about something else? Go do that if you want more of this, and that if you want something else.
And that's been absolutely fantastic, by the way. Actually, we could also just do a virtual round of applause as well, really. I think that was absolutely amazing. Thank you very much. So we've just got a few more minutes for questions for Ben. I did use the word tour de force, and I think you can see why. Ben, just while some people have posted some questions, perhaps I can just pick on one for now. Do you think the NHS would benefit from a charter which kind of set into stone this point about analysis commissioned internally or externally would only be commissioned if it's fully replicable?
Yeah, I think we should have a basic rule for all government data science, which is that all code paid for on the government's ticket should be open by default. I think making that the norm would shift assumptions. I think people often withhold code because they're anxious to give it away, or because their boss doesn't want it shared, or because they're worried about it being imperfect. I think funders like NIHR in academia, and tech transfer teams in universities, and lawyers in trusts in the NHS often give people unrealistic beliefs about monetizing their data management scripts. I think if we stated clearly that all code produced on government time or money is owned by the state, some kind of new equivalent of Crown copyright for code, then that would fix most of our problems, because it's not the same as giving it away. The state can then decide how and where to share with what limitations. not you, not your boss, not your, excuse me, I have quite a badly cracked phone that doesn't answer phone calls very easily. Yeah, we need to get to a world where you choose, you don't choose whether to share the code. It's not you, it's not your boss, it's not your academic funder, not your hospital, not your university. Default to sharing openly under MIT open license with the state able to make the choice. And that will prevent anxious blockers, making life hard for good people. It would reset all the defaults, and it would also push through a lot of people being anxious about sharing stuff because they're worried that it might not be very good. And that in turn requires that we're all beautiful and generous about other people's code not being fantastic, because often our code isn't fantastic. I've shared stuff where it's filled with comments that say things like, can't face doing a loop here, but you get the picture, rather than bothering to do a proper loop. And that's okay, it was good enough code, it worked from start to finish, it was fine. And I think we need to get grown up about that. I think I might have to let somebody in through my front door. I know that's tremendous.
Okay. Do you want to do that now, Ben? Well,
I think knowing what they have to do next and when school pickup is, I think I could say for another 4 minutes.
Well, I'll just take one more question then, Ben, if you are kind enough. You mentioned a lot about professionalism, and two of the questions kind of are along these lines of what tips do you have really for supporting leaders and decision makers to ask better questions of our analysts, and how can we make our analysts better at that dialogue with our leaders? So
I think there is no there's no working around the fact that to be an informed participant in a technical discussion, you have to have some technical skills. That is the bottom line. Now, I think you can get people in senior roles with good technical skills in two ways. Number one, you can make sure that the people who are promoted into senior leadership roles in the analytic profession are actually themselves analysts. I have very frequently met people who present themselves as representatives or senior leaders of the analytic profession, where they're undoubtedly people with good generalist management skills who have undoubtedly managed analytic teams in the past. But on closer questioning, it becomes clear that they couldn't do an inner join in SQL if asked to do so. And I think that's really problematic. I think you need to have people with technical skills move up the ranks. And in the same way that you get senior doctors in senior roles in places like NHS England or trusts who may not necessarily see patients all the time or indeed at all anymore, they have in the past managed thousands of patients. They have clerked more patients than they could possibly remember. Secondly, I think we need to have an expectation that people in senior roles, at least some of them, will go and do a Code Academy course in Python, or read a data science book, or read a Jupyter notebook with one of their colleagues and get a clear explanation of what each line is doing and what matplotlib is and what a shapefile is and how it works, and get involved in the mechanics. And I think if people don't embrace that kind of technical reality in the same way that they would go out and do a tour of the wards, in the same way that they'd go and do a visit down to A&E when the 4-hour wait breaches, if people don't engage with that technical reality, then they can't participate in the conversation, and that's a hard line. And we shouldn't pretend that hard line isn't there. That's the bottom line. That is the reality.
Great. Ben, just one more thing before we let you go, if you don't mind. This notion of some things needing a top-down solution, like, you know, Crown copyright for stuff that's done with public money, transparency, and kind of, you know, not having to negotiate things lots of times. Where do you, I mean, you know, you've been fantastic at trying to kind of galvanize these things nationally, but if colleagues on the call want to kind of join that movement in some way, what should they be doing? For example, the NHSR community would, you know, is a key, kind of signs up to everything you've described just now, but we don't have access to very senior leaders, the decision support network analysts, the West Midlands huddle that we do, and the colleagues that are, we've got about 200 colleagues on the call now. I think they would all want to be able to kind of make a contribution to this movement. So is there a focal point, or do we need to create one?
So I think we need an NHS Analysts Viking squad, and I think it needs to be open and permeable rather than charismatic single leaders or owners. I think it needs organisational support from things like NHSR community decision support units and AFA, but I think also it needs porous borders and everyday practical coalface analysts. So I've got Jess in my team who is fearless and up for it to take this battle on. If you're willing, Mohammed, to collect email addresses from folk here, and I'll give you an email to push around, then I think between us we can happily build up a I guess a mailing list of people who want to push for this sort of stuff to get pressed forward, and I think that's the only way forward.
Great.
I don't want to muscle in on anybody else's efforts, but I want to see it happen.
No, Ben, we would welcome some external or internal energy. Really, you're not at all external to any of this. I just have an image that, look, what NICE has done for clinical medicine. There is everything else around that hasn't had that kind of rigor and methodology and unification and kind of a sense of serving the entire NHS with public resource. And I think finding an equivalent of that would be actually great. So leave us with that task of thinking about that, to know that Jess in your team, who is also a tour de force, her work on the paper was fantastic. We will harness this energy and this kind of enthusiasm and come back to you, really. And I think it's a good thing for us to work on.
Hey, so, nice to meet you all.
Thank you, Ben. That's been fantastic. Great. Thank you all.
Sure.
Okay, great. So we are actually running on time, which is fantastic. And it's now, I'm now going to turn over to Andy. So the first thing to say to Andy is whoever agrees to talk after Ben just deserves a medal just for agreeing to do that, really. So thank you, Andy, for doing that. I'll just introduce Andi. Andi Orlowski heads up a newly formed economics unit at the Midlands and Commissioning Support Unit. This follows his success, really, at a similar role at Imperial College Health Partners. Andy has an MSc in Health Economics and Policy from the London School of Economics, and he's currently undertaking a PhD in matters relating to population management and risk modelling. His work on the clinical and budgetary impacts of change in oral anticoagulation will appear in the journal Heart very soon. Andy has a number of grant awards, including a recent quite prestigious award from the Health Foundation on the network data labs, which some of you will know about. So without any further ado, if I can hand over to Andy, please.
Thank you ever so much, Mohammed. You're very kind. And it's great to be part of, or soon to be part of the DSC, the Data Science Centre in the Midlands. And so the only way to follow Ben is to try and do a crowd-pleasing show of how we data analysts can help system leaders from falling into some silly mistakes. And I will go through some of those, the perilous perils of analytics, and how you guys there are the guys to solve these problems. But for you to then take some of this away to make sure that our analysts, our system leaders, the bosses, understand some of these perils. So when they're talking and commissioning the work, like Ben talked about, we can make sure that they're commissioning it the right way. They understand the perils, and they also understand the value that you guys can bring, and we can all bring to make these changes. But as Ben said, data and the analytics we can do are truly awesome. There's opportunities to improve the quality and safety and system efficiency, allocative efficiency. I never knew that I would be doing this kind of work when I failed GCSE maths twice and only passed on my third attempt with a C. And do you think that I now can help? Well, to be fair, much better analysts than me can help identify these improvements to our healthcare systems. We can evaluate new interventions and care pathways. So where medics and clinicians think, well, I'll try widget X or Y, Does it really work? The only people that they can turn to really understand this, to produce the beautiful counterfactuals, to be able to do the work to show that there is a difference, are us and you guys there. We can uncover health inequalities, and this is what drove me to become a health economist, this understanding of this huge differences of how people access and consume resources that's just not good enough, and how can we identify those. And of course, there is the performance and operation monitoring. And I know that this was the dull stuff that I did in the shit part of the estate when I was in a hospital, where they kind of put you in that dark porter cabin that nobody else wants to stay in. And but we've got to remember the performance and operation monitoring we do are for gigantic, organizations. There are very few private companies that you can get a job with that has a turnover, I say, of staff spending of about £2 billion. So if you're looking after Guy's and Tommy's, the Royal Free, I'm guessing MRI, these big hospitals, you've got thousands, if not tens of thousands of staff, huge sums of money to organize those. And so understanding the performance and how it operates is no small deal. Yeah, I've worked for private industry. None of the companies I worked for, large multinational pharmaceuticals, the UK presence was nowhere near as big as the small foundation trust that I started when I left. And finally, something that I care deeply about, population health management, and how we can case find and make life and care better for individuals as well as population. And I think this is something amazing that we can do. And so there's an amazing opportunity for us here. But of course, some of this comes with peril. And what we've got to remember is what Peter said at the beginning. Data is used for decisions, but who is asking the question and who is making that decision? And are they aware of the perils of the data that they can bring forward? Yeah, they hear or see something that they like from somewhere else. They think it could just be reproduced or replicated just like that. But of course, we know that there's more at risk. And there are some perils to come with just taking stuff. So first of all, data rarely represents the whole population. And so, it very rarely represents the whole population equally. Now, we know that electronic health records contain sicker people than on average, because of course, they're the guys consuming resources, which is a particular problem when we try to do whole population segmentation. And when we're asked to work out who will be sick tomorrow, because some of those people, if they're not consuming resources today or their electronic health records haven't been updated in a long time, we don't really understand. And so we can find it difficult to identify the healthy today to prevent disease tomorrow. So we know that the electronic health records may be a skewed population. And we also need to consider that the data that we do capture, does it completely and accurately capture the population as a whole? So even those consuming those resources. So what about those with the highest deprivation, or those populations less willing to engage with the system? Do system leaders understand that those people who may not want to share their data or have the least access to data may cause issues? And of course, these missing and poorly characterized populations may lead us to make decisions that favor the better represented populations. And that means we'll disproportionately overfund areas and with this increased activity and drive inequalities. So they think they're doing the right thing. They think that the data, even with the best algorithm, unbiased algorithm running on it, will give them the answer. But what we may actually do is end up driving the inequalities. And can data sets and algorithms travel? So many data sets tend to very well represent, with those previous caveats, the relatively small geographies they serve. So I'm very lucky that I get to work with WSIC, and I can see the amazing and gorgeous Vicky Evans on the line too. And we get to play with WSIC. It's 2.4 million people. We've got primary care, secondary care, community care, adult social services, mental health, loads of really cool stuff in there. But it's very specific populations for Northwest London. So models that we build here, are they appropriate to be used in other places that we work? So in Bucks or in Notts ICS. So a great example, in our own patch alone, we have Chelsea. So Chelsea is a pretty unique neighborhood with, there are more billionaires in Chelsea than I think in the rest of Europe put together, all crammed in this little pot. But just 3.5 miles away, we have White City. And White City, that housed the Grenfell estate, is one of the most deprived areas in London. And so an algorithm based on the data and data from Chelsea most probably cannot be replicated and run with the same assurance in just White City, just 3.5 miles away. So what we need the system leaders to understand is that we need to share the code openly. So exactly what Ben said. So how did we come to this code? What was the data that it was based on? Do people understand the biases, the problems that we have with that data? What can we do to make them better understand this? And of course, the algorithm that we've created may be biased by design. So what happens if it was built to built to have a look at the way of saving money? So we've got high users of resources. What we want to do is identify high users of resources so we can do something to them, so it will make them cheaper to look after. And so if the goal of that algorithm is about saving money, that may mean that certain people who could benefit from those interventions may be missed off. So let's say that's an intervention for COPD, and we find out that smokers are a key characteristic. So when we run the algorithm, we found out that the characteristic that most linked to the outcome we're trying to avoid is smoking. Do we then offer preferentially smokers the intervention? So that way, people who may have made a lifestyle choice that we may think is, I understand it's an addiction, but that these people may be preferentially managed over those who don't smoke, and the ethics related to some of the biases built into our algorithms. And also, we've got to be careful of the human biases between this. We know that there are 50 cognitive biases at least, and there's a wonderful visualization of these and how our own biases can cause these issues. So of course there's one of the big things is the confirmation bias, that we want our algorithm to work. Statistically, it shows that it does work, and so therefore we think that this must be the right answer. So do system leaders understand that we could have biased data and biased algorithms? And if we open up those algorithms, if we open up the data to the people to be able to understand the reason it was built and the results of it, do we then mean that when it moves, when the local analysts take it on, it will be a better output in the long run? So I have to be careful of those. And finally, data and decisions that won't change care. So models are usually assessed by the measures of statistical accuracy and not by the model's ability to improve decision making. And to be fair, I too have fallen into the trap, and when we've been running versions of PAR or PAR 30 or the combined model, risk models, to identify people coming into readmissions, we tweak it with local data, or we add additional data sets to try and hone this and get the best possible responsiveness, trying to make sure it's not too overfitted. But of course, if we can't make a difference in these patients, it's just not going to, it's going to be of very little benefit at all to the population. So we have to be aware that models may identify people who will simply get better, so regress to the mean, and while others identified may continue and may be identified, and by the time we get to act, they may have passed away. So targeting additional resources at these patients may have no, little, or potentially a negative effect on an individual's outcome, with triple fail events or even an over-medicalized death. So I'm going to share some slides, if that's going to be okay with you guys. If I can do my screen share. If I do this and do this. Hopefully, so now I can't see you at all because my two screens have stopped me, but I'm hoping that you're seeing a wonderful black and white picture of a guy from Eastern State Penitentiary, and this guy is Slick Willie. And so William Sutton, aka Slick Willie, was a famous bank robber. When the FBI created the first ever most wanted list, he was on it. And so he used to dress them in disguise, go into banks, and did a very good job of robbing them. So he was caught 3 times, he escaped 3 times, and he became a bit of a folk hero to the Americans. And when he was caught for the 4th time, as he was put into the back of the paddy wagon, they said to him, you know, Slick, why do you keep robbing banks? And the Paps were there, and he said, why do you keep robbing banks? And he said, because that's where the money is. Yes, so the obvious answer. So clinicians and medics are still taught this today. If you hear hoofbeats, think horses, not zebras, you go for the obvious. And this is what I was taught when I was in the NHS. And this is what I believe system leaders think. If it seems the obvious one, the most obvious answer is the right answer. But we know that Slick was a con man, and he's still conning us today. Yeah, so there's this concept of impactability. We identify people with our risk models. We identify people who may be at risk of a readmission, but can we actually have an impact on the outcome that we're measuring? And Slick, even though that he may be right and that analytics may be right, we have to ask some additional questions. You know, are there gaps in care that can be closed? Are there, ambulatory care sensitive conditions that can be dealt with in a different situation? You know, are there opportunities to change the intervention to better meet the individual's needs, because they come from a different culture and need a different approach to be able to manage it? And there's a classic example of having a look and Slick's law let's say Sutton's law in happening. And so let me just show you. So here is a Vanguard, or some data from the Vanguard. And as you know, the Vanguards were asked to reduce the number of hospital admissions per, or certainly the readmissions. And so we're really, really keen to have a look at this program. And what you see here is, us doing some great work to have a look at the readmissions per month per head. Then, of course, because we're trying to be the best data scientists we can, we have a great counterfactual that's very, very close to the original population. And here we go. What happens is they come in, so we need to put an intervention in place here. And as you see, the kind of intervention worked extremely well. And everyone is cheering and happy. And but then, of course, what we found, bollocks, it didn't work. And we found out that the control group actually did better. And this is the whole point of impactability. We've identified this group at risk. We've put, the intervention in place. We've spent resources on those people to actually make no, or in fact here, a detrimental effect to the outcomes of the, of the kind of intervention. Let me just stop sharing. And so, so hopefully that kind of gives you a real view of the kind of the potential errors that you can have, in a system. So what are some of the solutions, and how can, your local analyst help? And so I very much believe there's a human element to understanding our data and our populations. I strongly believe that local analysts with experience of their neighborhoods are essential for making the best use of data and helping system leaders make the most informed decisions. You know your data sets, you know your populations, you understand if the data looks spurious or there's aberrations that can be checked. If you didn't know London at all and you suddenly saw a return for thousands and thousands of millionaires and billionaires and all these rich people in Chelsea, you'll think that the data's crap. But actually, because you live there, well, not that any of us live there, no one lives there, it's too expensive, but you know that that's where those guys are. You also know that the neighborhood next door, White City, has those, those same issues, and it's the same for all of you. You know your populations, and so you can interrogate the data, and you know when to push, and you know when to have a look. And a key part of this is sharing, and as Ben said, it's making sure that if we're new to patch, or if you're kind of working in a team, you get other people to kind of check this. And so system leaders need to understand, it's a key part. Your personal network. So for analysts, I'm so glad to see, so so many awesome people on the line. They may not still be here. They may have dropped off because they find me very dull. But the gorgeous Glenn Howard, I've mentioned Vicky Evans, there's Kate Chima here, all awesome guys who over the years, I swear, I've nicked code from or nicked ideas from, claimed them as my own, may have bought them a pint in the pub, but I doubt it. But your personal network and your analyst's personal network is a very, very powerful thing. You won't believe how much your local analysts can do. And so system leaders who feel that they have to outsource to find some of this stuff, that's not true. Our personal networks are incredibly strong. And also our professional networks. You know, we've mentioned AFA today, and it's an amazing opportunity. It's a great charity that I believe in the next year or two will make a huge difference. But locally, certainly in the Midlands, we've got the DSC. Yeah, we've got this incredibly powerful network that's built to work and built to share together. And so more of the DSCs, more of what the strategy unit and NRCSU have been doing, because that's what's going to make the difference. You know, and if you need to join these things, you know, AFA isn't very much, but you know, I urge you to join today, and you know, it will pay you back in dividends, I promise, in the future. And if you can't pay, get your boss to pay. I know that I paid for my team to join at Imperial, so make sure that you get your team and pay for them to join and be part of the community. I also believe Ben's comments around free range analysts. Yes, we need to not be isolated in, you know, again, in the crap part of the estate, but we need to work in teams and be embedded in mixed teams with clinicians, managers, researchers, the software engineers, if there are any, and also the great communicators who will sell for you, who will wave the flag, who will be the shouting Viking at the front of the boat, because we need analysts to work together with other people. One way is it deals with impactability. So one of the problems that we have where we make decisions that can't change, by working with clinicians and managers and others, when you say, oh, well, these are the issue, we'll do this, they will understand if it'll happen or not. And so it's a key part to making a big difference. But analysts should be led with someone with expertise. Yeah, you need to have someone with some technical skills. And you know, I am a generalist. I don't know much about machine learning and AI, and which is another reason to go back and do the PhD. And it's a kind of a key bit to be able to understand. But I've been an analyst. I've had to do the work, and I've had to kind of spend days and weeks cleaning data sets. I've had to spend days and weeks working out where the hell in the code that bloody mistake is that I can never bloody find. I too have been there. So when your people say the same thing, you don't just say, there's my answers, get it now. You understand the pain, and it's a learning journey. Yeah, and so it's a key part that analysts, I believe, should be able to be integrated, but also to be with others to learn from, and certainly someone to lead them who has some expertise. And so what next? What can we do from Ben's talk? What can we do about sharing the perils? And system leaders, if there are system leaders on the line, please speak to your analysts first. Yeah, if you're going to make decisions from data, please go and chat to them. You will find them. You've seen today, when people turn their cameras on, pretty much every analyst looks like they should be in a boy band or a girl band. They're all extremely handsome. They're exceptionally well endowed brains. They're often incredibly well dressed. And certainly if you work at the strategy unit, you've got a beard. And so, and that's, you know, I see Rachel on the line, so maybe Rachel shared her beard today. But your analysts are a friendly bunch. They want to talk to you. They want to work with you. I had no idea when I started out as an analyst that I could do pop health management. You know, the idea that I could make a difference for a system that could benefit people was absolutely outstanding. So they will bite your arm off. They will truly bite your arm off to be involved and, you know, and to make a difference, yeah, to help you make these decisions. And for the analysts, I know you have to start smashing the swords and shields together. You have to start sharing what we can do, yeah? We can't just leave it to Ben or the DSC or to AFA. all of us have to make a bit of a stand here. So what can you do to get in front of clinicians and clinical colleagues and medical colleagues to share the awesome shit that you do? There's amazing stuff that we can share. So please, let them know. If you're an analytics boss, so the A's, B's, C's, D's and above, it's your job to go to the other senior management and make sure they understand what your team can do. Yeah, because otherwise the investment leaves the system. Otherwise, people won't understand. And it's your jobs as the managers to educate the other managers on how to ask the right questions, that you shouldn't just be settling for simple regression. There are better things that you can do today. There are better things we can do than just reporting the same crappy reports that we send in every week, which we know you don't read, because Tableau, ClickView and Power BI tell us that you don't read them, because we have all of the reports from that. So, it's your job, analysts, to go out there. We need to upskill the bosses, upskill colleagues in improvement, let them know what we can do. And share the info, and as the Goonies say, now is our time. Yeah, we're the odd ones. We're sitting at the bottom of the well. We are the ones who can make a real difference here. And I think COVID-19 has shown us how valuable we are to the system in being able to direct resources and to be able to help make decisions. So now is our time to kind of start the Viking invasion, to use Ben's words. But thank you ever so much, and sorry for the rant. Cheers.
No, Andy, that's great. A round of applause for Andy, please. Thank you very much. Thank you for that passion, Andy. That's great to hear. We've got a few questions, Andy, if I can just read them out for you. So one of the questions is around, if you think, just relate back some of your comments about population models versus person level interpretation. What do you think? Do you think that has anything to say about the exam fiasco?
Yes. Well, I think that shows a wonderful output of the issues with modelling exam results by taking people. I'm guessing, wouldn't it be great if they shared that code so we could have a look at it? But so I came from a working class family. My mum was a cleaner. My dad was a squaddy. They didn't have a single qualification between them. And I'm the first in the family to get a degree, a master's, and fingers crossed with your help, Mohammed, a PhD. Obviously, not too much help that it's illegal, but there is much room for social mobility. We grew up in a poor part of Lincoln. I'm pretty sure on that algorithm I would have been stuffed. And but again, this idea of trying to fit these distribution curves and those the errors and not understanding that that these individuals can move and outperform is a huge issue. But again, this comes down to decision makers and people calling the shots, not really understanding the problems with I say a person compared to a distributed 2.4 million. And the fact that we have to make decisions on the one that benefit the one, but when we're planning, obviously we have to plan for the whole. So you're absolutely right. That's a great example of the potential perils.
Thank you, Andy. Just another question that I'm again just reading from the chat or paraphrasing. One of the challenges for analysts is really how they kind of avoid being micromanaged by leaders or managers or supervisors who don't really have domain expertise and are essentially stifling really the work of the analyst, or possibly even channeling them in a direction where the analysts may not even feel that this is the right way to go. Did you experience that in the porter cabin that you worked in, and do you have any tips at all?
Yeah, and I suppose it must be very nerve-wracking and potentially very stressful for managers when you're sitting in front of the bright analysts that they have in front of them, who understand data, who are talking a language they don't speak. And the programs that we talked about today, the software that we use, they have no concept of some of the approaches that we use. Again, they don't really understand, and it's a big part of what I believe we as the managers of analysts have to do is to make sure that other people in the system are educated about this. And if you are one of the analysts being micromanaged, what can we do to upskill them, to help them better understand how they can, the benefit of allowing you to go through, the work in the right way, and to be able to push back gently when you're being asked to do one kind of approach when the second approach would be much better. And it's my life has gone full circle. I was, when I very first started and left university, I was a sales rep, and I feel that after what's 25, 26 hard years, I've gone round all over again, and I spend my entire time selling the ideas of what we can do and the capabilities and the possibilities. And so it must be very frustrating. And I was in that boat, as you say, in the porter cabin. But it's, what people can do now with machine learning and AI, it's another, huge leap above. And again, system leaders and decision makers may not be aware. And so they start pushing for the old ways that they understand. And it's that's a key step of what we have to do, is education, more and more, the more talks.
There is one more question, and then I will probably hand over back to Peter, I think, or to Rachel or David. Anyways, but we will do a handover back in a short while. So the question, and if an accountant was managed by a non-accountant and was asked to do something which wasn't, according to professional standards and so on, they could draw on their profession to support them to do that. What should our analysts be doing when they're nudged into that kind of position, really, do you think?
Well, I think that we've got, if you're in the Midlands and you've got and you're part of the DSC, I think you've got a wonderful opportunity to be able to reach out to the group and say, is this the best approach? And then to be able to go back and respectfully push back and say, look, this is the right way. I've worked with colleagues, my personal network, professional network. They agree that this is the best approach. This will give you the best information to make a decision. AFA has a role to play here too, but I think it's these active ones, like say, where AFA is going to help professionalize us and start waving the flag and shouting at the highest levels. It's things like the DSC on a day-to-day basis, where you can flex in and say, look, I've had someone have a look at this. They've said that I've looked at both approaches. They also recommend approach X or Y. Do you understand, or are you happy for me to proceed? You've had external validation of this. But again, it's a hard job to do when you're a 5 or a 6, yeah. And some boss comes down and says, a recent one where we're looking at creating contact information. So how many visits we have in primary care, secondary care, and obviously you've got to get the codes. What codes are important to look when you're looking at activity? And then someone just going, well, what's the bloody answer? We said, well, we need the clinicians to tell us what the codes are. What are the appropriate codes? And of course they go, no, but we need the bloody answer. It's really important. And you go, yeah, but and then it's this, it's how we push back. But again, it's our job, Mohammed. There's Peter, Fraser, it's you guys in the Midlands, all the bosses, who are here. It's our job to help out and to help educate and share what's doable and stay patient.
I do think that one of the things we might, just as a left field suggestion, is as Faulty Towers was a really nice comical way to show some really awful behaviour. We should just try and create some of these cartoon type or kind of devices, really, which can be humorously shared with our leaders. When the leader said, I just want the one number to know how many I need of X.
Yeah.
But anyways, we can think more about those things. So look, that's been great, Andy. Thank you. I will hand over back to Peter. I'd like to thank all of you, by the way, for your contributions and kind of staying with the online sessions. This has been our first one, so it's been great to have your engagement and contributions. I'll hand over to Peter. Thank you.
Thanks, Mohammed. Thank you everyone for taking time out of your day to join this. I hope you found it stimulating. You can see on the slide here what's coming up this week. Session about the impact of COVID on social care, what that means for the future of social care. Got a great panel for that, including a couple of people of lived experience contributing to that discussion. Got Ipsos Mori on Thursday talking about some of the ways that you can push engagement to perhaps more of a level of research to start producing statistically significant information back in terms of population perspectives about trade-offs, for example, choices, about priorities. And then we've got a panel discussion at the end of the week with colleagues from the Health Foundation, Nuffield Trust, to talk about, and the strategy unit, to talk about some of the work that was done as part of the analytical collaboration for COVID. And then just a plea really, please stay involved next week when we're talking about the DSU arrangements, because a lot of the things that Ben and Andy talked about are absolute foundational principles for how we're trying to set up the decision support arrangements in the Midlands. So things about how we're going to share code, how we share knowledge. We've got a set of principles developed, including Creative Commons principles for our knowledge library. We've established as a matter of principle all of the big analytical projects that are done by the Decision Support Centre will be produced in openly shareable code available to anyone in anywhere to adopt or adapt. You know, we're absolutely determined to champion those principles and to make this a network that really becomes greater than the sum of its parts, but starts from the premise of building local capability first. We've had the privilege to meet fantastic analysts and others as part of the work we've done on population health management over the last year, many of whom are not having their skills well deployed. And our proposition is the NHS has got most of the capability it needs, it just isn't very well organised at using it. And so our belief is that a network model is the way to achieve that, rather than something unreasonably hierarchical. And then on the last one, Andy's point, I think this issue of unpacking the philosophy that sits behind algorithms is really important. The exam one was a great example. At a population level, trying to achieve a distribution that didn't overinflate grades is a reasonable objective, but nobody thought enough about what it meant when you translated that down to an individual level, when the utilitarian philosophy that underpinned the overall analysis collapsed. And we really need to think about that as we leap into population health style algorithms, that we are really investigating and discussing the philosophical underpinnings of what we do, as well as the technical underpinnings. Anyway, thank you so much. Please stay involved, give us lots of feedback, tell us how we can make these sessions better, and we look forward to welcoming you to as many in the future as you can make. Thanks very much, everybody.